Hello, my name is Tim Dixon. I'm the Executive Director of the Pharmaceutical Industry Labor Management Association, and I want to welcome you to the series of webinars that PILMA is presenting on issues that are of direct interest and have impact on our members, not only members in terms of the organizations that belong to PILMA, but the actually working families that work in and around the construction sector to support the biopharmaceutical industry. As you know, PILMA has been in existence for nearly 20 years and is a coalition of building and construction trade unions, the police and fire unions as well, with the biopharmaceutical industry member companies. We wanted to talk today about substance use disorder and addiction and support that both the industry and our members in the building trades who are members of PILMA extend to their members. Just one quick statistic, and this is over a year ago, the latest numbers captured by the CDC showed that more than 81,000 overdose deaths from drugs occurred in the 12 months ending in May 2020. And that's before the pandemic. We felt the full assault of the COVID-19 pandemic. But at that time, it was the highest number of overdose deaths ever recorded in a 12-month period. And the reason why we wanted to talk about this is because the construction industry has really, sadly, moved to the fore in terms of the impact that substance use disorder and abuse and addiction has faced its workers. It's self-evident perhaps why, and that's because of the culture of work. If you don't show up at the job site, you probably don't get paid. If there's a way to approach the work in a better way, people are eager to do it, but it's dangerous work. There's repetitive stress involved in construction work. There's lifting, there's objects, and it's a place where pain management comes into sight. So we're very fortunate today to have two experts in this field. One is Cheryl Ambrose, who works as the Director of Health, Safety, and Environmental Administration for the UA, for the United Association of Journeymen of Apprentices, Plumbing and Pipe Fitting Industry in the United States. And Cheryl works as the administers safety programs, not only in terms of OSHA, but also has acquired the responsibility for managing the UA's approach to taking care of its members with substance use disorder. Real quickly, the other person that's going to work with us, and I'll introduce him later, is Mark O'Brien. And Mark is a leader and a subject matter expert with the RX Abuse Leadership Initiative. And we'll talk about Mark in a minute, but I want to stop talking and get to Cheryl's, because the UA has, the Plumbers and Pipefitters have done amazing things in taking care of their members. And this is just one of them. And Cheryl, we're so lucky and glad to have you here.
Well, thank you a lot, Tim, and thank you, to PILMA for the invitation. Anytime we get a chance to talk about this subject is always a great thing. And so I'm going to go ahead and share my screen so we can kind of get started here. And hopefully, there we go. And so, yeah, this thing, and Tim, he hit on some really, really important things, and I appreciate the introduction. When we started on this journey, and what I'd like to do just in the time I have here today is really to kind of walk you briefly through the journey that we've undertaken here at the UA with regard to substance use disorder, opioids. And it all really got started, I think, at the high level back in 2018, when, as many of you may be aware, NABTU, the North America's Building Trades Unions, formed an opioid task force, and I was appointed to that task force by the General President, Mark McManus. And, I've been an occupational safety and health professional for, over 25 years, going on 30 now. But I have to say, I'm not a mental health professional. And so, this was an area where more and more occupational safety and health folks are finding this as part of what we do, broader than just maybe managing a drug testing program or managing, all the things that go into that, whether at the DOT level or non-DOT. So we put together, and I should say NABT put together, a really fantastic group of folks. And really what this started out was about starting the conversation. Because unfortunately, it's time to get uncomfortable, and that's kind of where we were. And it was, I can say, even from me, I'm really interested to hear what Mark has to say, because I always love to hear from the guys who are really in the trenches, working with this on a day-to-day basis, and anything that we can garner from that. And so with the task force, we were able to put together a number of people and really start tackling this thing from just starting with how we talk about it, looking at it from the stigma and the things, vetting treatment, peer advocacy, all of these components that go into this big, broader issue. So Tim touched on some really glaring statistics. Of course, we know that there've been, almost 400,000 Americans died as of 2017. And then fast forward, we were at 130 folks a day dying from opioid overdoses. And then in 2020, we saw this big spike, we saw this uptick, and without even factoring in the overall effects of the pandemic, this we know is part of it, but these are some pretty staggering numbers. So when we look at that and say, wow, maybe that's numbers, but I will tell you that from my perspective, it also became a passion project for me to get the word out and figure out how we can do better on this subject within the UA, because I have a family member that I lost to a prescription opioid overdose back in 2014. And since then, I've learned a lot. And while I think we all probably understood this, looking at it specifically, the impact on the opioids on construction, and Tim touched on this as well, is that our members are disproportionately affected in the 6 to 7 to 1 range over other occupations, other industries, other demographics, in terms of, and these are just some statistics here, that we have picked up on. And if you haven't had a chance, and if you are familiar with the state of Massachusetts, their Department of Public Health, Trish Davis, who actually is one of the members of the NAB2 task force, they put together a pretty fantastic study, which came out last year. And they had already done, statistics. They'd already done research, and they knew that we were already disproportionately affected in the construction industry. And so, of course, the statistics from last year have borne that out. So we took on a training initiative, and one of the things obviously we touch on, and for those who are very familiar with this, we have to break down some stigma. We have to be able to talk about this in a more, as we say, it's time to get uncomfortable. It's time to get comfortable with an uncomfortable conversation. And some of it's just generally, we start with the basics, explaining to folks and talking about the effects of opioids and other substances, but particularly opioids, and the physiological change that can take place in the brain. And I can tell you that I have probably been guilty of this in my lifetime in encountering folks who struggled, including my family member. This is not, and I had to wrap my head around it. It's not a lack of willpower. It's not a moral failing. This is something that really does have a physiological change on the brain. So when we were coming through, working with the task force, and looking at where we wanted to go with this from the UA's perspective, in the many committees that I sit on, I work closely with the NIEHS, and they were in the process and had just brought out their opioid training awareness program. It's an awareness. And so I approached them, and I had the conversation with some of my colleagues there at NIEHS, and I said, have you ever considered doing a trainer program? Because if you don't know a lot about the UA, our main model for getting training out to our members is through our instructor training program. So we have UA instructor-led trainer courses. We get together once a year. We give them, cutting edge, top of the line training in all aspects of everything that we do as an international union on all of our trade levels. And then of course, safety is part of that. So that is our best mechanism and our best platform to get information to our members, to get it right out there to the members, is through our training centers, our JATCs. So when I approached NIHS, I said, hey, would you like to do this training? Could you do it as a trainer course? They're like, yes, we'd love to. We're actually in the process of developing it. Would you like to be part of that? And I said, absolutely. So, we took it on from the perspective that we had been working on with NAB2 and the approach there, which is the public health model of the primary, secondary, and tertiary prevention. Looking at injury prevention, raising awareness, access to appropriate treatment for injured workers, not just having them become medicated in order to get them back to work. Access to support, for treatment and recovery, and then looking at what is that next step after recovery in getting them back into the workforce, so that they become, they become a viable person back in the workforce again, which is what they want. So when we got together with NIHS and got this all put together, the goal was then to finally be able to send anyone who took the course, the instructors, back to their locals with a turnkey curriculum. And so just to kind of give you a little background on the timeline, we debuted it in September of 2020. Our goal was to actually do it in August of 2020, which is when we do our in-person instructor training program. Unfortunately, because of the pandemic, many things were in-person gatherings were canceled, and our instructor training program was no exception. That unfortunately did not hold in person, but we went ahead, pushed forward with a virtual model, and we were able to get that off the ground, only piloting it a couple months behind schedule, and then following that on with another course in November. So we've brought together some UA instructors who, this kind of happened really organically. We found people who were very passionate about this topic, and they wanted to do something to help members. So we have our instructors who really have jumped in with both feet. We have guest speakers that are UA folks that generally have a personal story that they share, that really kind of sets the tone, helps the class then become a safe space to start sharing. And that's how we start. We start breaking down the stigma. We focus in on peer advocacy as part of member assistance, because each of our locals, will have something a little different in their area. And some areas are having bigger problems with this than others. But I would say that there is probably not a UA local and probably not a person out there who hasn't been affected by this in some way or another. The other thing that we really wanted to take into this training was a discussion about suicide prevention. And I know this isn't necessarily driven by suicide, or our discussion here today is not on the suicide front, but I felt very strongly that we could not address this topic adequately if we didn't talk about it. And because for those of you who may be aware, we have a Veterans in Piping program, which we've seen phenomenal success. And Mike Hazard, who is our training specialist out of the International Training Fund, who runs that program, Mike was equally passionate about this. And so Mike actually comes in and talks about suicide prevention and some of the work that they're doing on the VIP front, because we have fellows, we have folks coming out of the military who may be struggling with issues. And to borrow something that Mike said, he said, I got tired of sitting around crying about it. It's time to do something about it. And that's kind of how I felt. So Mike's been a great asset, and we really are glad that we've been able to talk about that as well. And it gets people, broadening their thinking about this whole issue. And then we look at it, obviously, our course is called Prevention and Response. So it's not just to respond, we want to prevent people getting into situations where they may then find themselves in a situation where they have substance use disorder and fighting addiction. One of those ways is to prevent the musculoskeletal disorders. And with through a NIOSH grant the year before we launched this course, we were able to develop an ergonomics, basically preventing soft tissue injuries course that we've built into all of our OSHA courses, and that those materials are available. And then we also include that as a resource in this course to sort of reinforce that and hit that home, because our guys, they're going to, Tim hit on it. You don't work, you don't get paid. They wake up, they're hurting, they find a way to get through the day, and it may or may not be a good thing. It may be, hey, let's take this prescription or go get a prescription, and then they're off down the slippery slope. One of the things that's really been instrumental to us in the training is the short and long-term feedback. So we've had the ability to do that through NIEHS. So we've looked at it, initially after the course, and then of course 6, and we're looking to do it a year down the road as well. I wanted to just share with you, because in our initial feedback, I thought that some of these things were fairly interesting, and wanted to share when we ask these questions, kind of where people are. And we call it I put a pretest here, but it's really just a pre-course evaluation. How comfortable are you discussing, the severity or the opioid crisis, stigma, working conditions? Are you comfortable in doing certain types of training methods and talking about this? And so we got a little higher on the training methods because these guys are all instructors anyway. But what was really, really encouraging to me, and to all of us that are involved in this training, was that from the beginning to the end, wherever they were in the beginning, they were at 100% at the end. So that's been really great. And then just being able to take this back to their locals. And so just to talk about next steps, where the UA is looking to go with this. Of course, we'll continue to conduct the trainer courses on the things I mentioned earlier, the opioids, substance use disorder, suicide, and prevention. But then looking at the peer advocacy piece and the training there, and how that can then become a critical piece to support member assistance programs. Because I will tell you that the uniqueness of the labor movement and the labor unions is that in my career, I've worked in a number of union contractor situations, is that there's a brotherhood and sisterhood. And when they reach out, people need help. It's amazing. Just in how this course came together was just a pure example of, and the genuine people wanting to help. Big burly construction guys in the course getting very, frankly, emotional, sharing some of the stories. So the peer advocacy piece we know is a big next step. And so we're actively working with NIEHS to develop that. And really, and that's why I have to come back and thank Tim again for the invitation, because we just have to keep the conversation going. Even if it's uncomfortable, we just have to be able to keep talking about it at every level, not just, in the classroom, in the training. We need to make sure it gets down to the people that need the help, get them out of the shadows, bring them out of the shadows so they can get the help, break down that stigma, but also create the awareness so that we're having less and less people find their way into that situation. So, I just would like to end with the fact that the journey's really just begun for us. And, we feel like we've done a lot. It's been a great first beginning, but we know that this did not happen overnight. It's not going to get fixed overnight. And we know we have a big journey ahead of us. And so, but, our members are our most important part of what we do. And so we're in this for the long haul. And so with that, I'll just say thank you and turn it back to Tim.
Cheryl, thanks so much. We did get a question from Lee on the West Coast. It was the question that it kind of touches on the question that I was going to ask you. And I'll just kind of take Lee's question to frame that out. Lee said that asked about the issue of testing on the job site. And, this is a very precarious place because the the UA and the affiliate unions of NAPTU have prided themselves on zero tolerance for alcohol and drugs on the job site because of the premium placed on safety. And you don't want to be working, 30 stories up as an iron worker, riveting an I-beam together with someone who's not completely cogent. But at the same time, it's difficult. The difficulty lies in the culture of caring for members, and you don't want to just leave somebody behind. So, how does the UA approach that, and maybe thread that into a little larger discussion about what do we do about CBD and treatment and cannabis? Culturally, society's moving in a certain direction, but that creates some real, booby traps for the construction industry.
Yeah, and that's a great question. And it's unfortunately, I think, doesn't have an easy answer. As we had talked the other day, the drug testing and, having worked for years and dealing with various substance abuse programs, this whole one and done. And so I think there has to be a broader discussion is say, we don't necessarily want to let go of the fact that we want our job sites to be safe, and we need these mechanisms to do that. But then how do we take that to the next step? So then, what is the next step? What happens to that person when they don't pass the drug test? Are they kicked to the curb? And I hate to use the term, I don't want to necessarily say it's a safety net, but where's that, are we saying, okay, well, certain JAT or certain locals may have a program in place where, and depending on how it's in the CBA, and we have of course, we have so many different ways that this could come about, that they would have some support there at the end and then be able to come back into the workplace. I think the sooner that these things are actually discovered and supported, we can help someone before it becomes such a dire situation where they're in long-term treatment, medical assisted treatment. How do we handle that in drug testing schemes? And, I'm going to actually defer to Mark. Hopefully Mark can maybe even talk about this a little bit. I don't know that we have an easy answer. We would really, and I think there needs to be a hard look. And then we have other regulatory agencies. So I brought up DOT earlier. So PHMSA, we fall under, we have members who fall under that. And so they're tested based on the DOT regulations. And there's not, that DOT is pretty prescriptive in what happens there. So there is some ability to bring someone back, but there's under certain circumstances. So but when you get away from DOT, then it's kind of all over the place, and so the substance abuse, or I say substance abuse disorder, but determining whether the drug testing programs, that's something that the task force, we have wrestled with. We really have. We're looking at that too, because that factors into all of this. Obviously, we get the awareness on the front end, but to be able to come back around and get that person back in the workforce ultimately, so that we're not just casting people aside and saying, yeah, well, okay, sorry for your bad luck, but you can't work here anymore.
Well, that's especially true with apprentices because they're a younger cohort, and you got some young kids starting maybe in the first or second year of apprenticeship, and they're younger. I have 20-some-year-old boys, and there's some issues that have to do with indoctrinating that into the apprentice program so that they can know the best ways to do it.
Yeah, and there's been discussion, I know, on the NABTU front, and actually making this training a required part of the apprenticeship program. I don't believe that there's been any decision made on that, but I know that there was people that felt strongly enough that it really needs to be brought out there. But we do have a number of the locals that are, putting together their own programs and really getting on board with this. And they were excited that we had done something to kind of give them those resources to at least get started. So. Well,
Cheryl, thank you so much. I mean, your personal perspective on this is so important, and it just goes to show how, you know, you take care of your brothers and sisters at the UA, but folks like you, you know, across the building trades unions really, you know, every day get up and try to not only put their member on the job site, but take care of them while they're there. So thank you for not only for participating here, but for your service to working families and working men and women. And we're hoping that this will be the start of, you know, more collaboration with RALI.
Absolutely, absolutely. We would love it and would welcome it. And I am honored to be here. And so appreciate the time. Thank you very much.
Very good. And that leads us to our second subject matter expert. That's Mark O'Brien. Mark is a subject matter expert with the RX Abuse Leadership Initiative that was started some years ago. Mark's got over a decade of experience of advocating for and implementing really smart policies and practices to prevent and treat substance use disorder and support recovery. Before he was working with RALI, he was Baltimore's director of opioid overdose prevention and treatment. And he was also served as director of communications and senior policy associate in the Legal Center's Washington, D.C. office. You know, as part of his work, Mark is a member of the National Academy of Medicine's Action Collaborative on combating the opioid epidemic. And I hope, Mark, that you'll be able to tell us the great stuff that, you know, in a very short time that RALI has been able to do to formulate a response, pull in industry participation and the kinds of things you do in the States. So I'll leave it up to you to tell us your story.
Thank you so much, Tim. And I really appreciate the warm introduction and the opportunity to be here with you today. Getting my slide presentation up for sharing. I think I'm good to go here. So I just want to say good afternoon, everyone. It's such an honor to be joining you today. As you just heard from Tim, I'm Mark O'Brien with the RX Abuse Leadership Initiative, or RALI. I've spent the last decade and a half working for various nonprofits and local government agencies in DC and Maryland to improve our responses to addiction. I want to thank PILMA for bringing us together today, and all of you for attending and for your interest in addressing what I think it's fair to say is one of the biggest challenges facing our country right now, the addiction crisis. I also want to just kind of build on what Cheryl was saying and sharing with us, and just say how sorry I am, Cheryl, for your loss, and grateful for your willingness to be vulnerable and open with us about it. I think it's so important. You mentioned the stigma that can sometimes surround this disorder of addiction. And, you know, I appreciate your saying how in the past you may have thought of this as a moral failing, because I think many of us have felt that way when it comes to addiction. And I would be lying if I said that before I got into this work, I didn't occasionally feel that way about it too. And it's hard. And you brought up some of the brain science that shows that this really is a disorder that physically affects the brain. And I loved the graphic that you shared. And it really, I think that was what drove home for me, that this is a disease like any other disease. And it can be hard. I'm a parent of 3 young children. And we see these photos, and I think this is, you know, we've seen this more and more as the opioid crisis has escalated, of parents or guardians who are with children and have overdosed. I think there was kind of a sensational photo of a couple in the front seat of a car with a child in the back, and they've overdosed. And for me, that was really, you know, even having worked in this field for a while, when I first saw that was really hard for me to wrap my head around. But the more I got to understand the science, what I learned was that when somebody develops an addiction, the survival part of their brain, this really ancient part of our brain called the amygdala, that is the survival hardwiring, is really what gets hijacked by that addiction. So these parts of our brain that tell us to get food, to seek shelter, to ensure the continuity of our species by having sex, having children, and then caring for them, are the parts of the brain that get hijacked. And so the brain learns that the substance is more important than all of those other drives to survive. And at the same time, we have damage to the prefrontal cortex right up here. That's the part of our brain that allows us to override our impulses and to think rationally. And so at the same time that this survival kind of instinctual part of our brain is telling us that drugs are the most important thing, the part of our brain that normally is pumping the brakes and saying, no, stop, that's a bad idea, is not functioning the way it should be. I think for me, that's always been really eye-opening. I want to tell you a little bit about RALI. See if I can, there we go. RALI is, we are an alliance of local, state, and national organizations committed to finding solutions to end the opioid crisis. We focus on educating the public about preventing opioid misuse, spotting warning signs, and talking to a loved one if you suspect there might be a problem. We also exchange best practices and provide resources that help prevent misuse of prescription medicines. And we currently have over a dozen state chapters, and we've conducted educational activities and events in several other locations. One of our educational projects that I think is just really neat is the RALI Cares trailer. And this is a project that we offer in partnership with Code 3. Code 3 is a nonprofit founded in 2015 by ex-law enforcement officers with a goal of improving relationships between law enforcement and the communities that they serve. The RALI Cares trailer is a simulation of a teenager's bedroom or a young adult's bedroom that these former law enforcement officers use to educate parents and other concerned adults about the signs of addiction and what they can do if they're worried about a young person in the family. The in-person tour looks at signs you might find in a closet, bedroom, bathroom, on a desk, around the floor, in a young person's room. And we've taken the trailer all over the country. But with COVID, we really weren't able to do that over the last year. So we've been doing live webinar tours of the trailer. And we also created a virtual self-guided tour that you can take online at raliusa.org. So that's RALI USA.org. And you can see it right there at the bottom of my slide. I definitely encourage you to check it out. Share it with people you think may be interested. You just click on the RALI Cares link at the top of the webpage and scroll down a little bit, and it's easy to find and navigate. Another big part of our educational efforts has focused on medication safety and safe disposal of medications. RALI has promoted National Prescription Drug Take-Back Day, which happens twice a year in the spring and in the fall, and our partners have distributed medication disposal pouches to communities across the country. The drug disposal pouches are really a great tool for families who want to prevent prescription drug misuse and who may not want to wait for a drug take-back day or go to a drug disposal site. Pardon me. You just put unused medications in these pouches, you add a little bit of water and shake. There's activated charcoal that deactivates the drugs in just about a minute, and it's environmentally safe. So when you're done with it, you just throw it in the trash, and it's perfectly safe to dispose of that way and environmentally friendly. So that's a little bit about who RALI is, but now let's talk about what is really bringing us together today, which is what's going on with the opioid crisis and what are some things we can do about it. And right now, we really can't talk about the opioid crisis without also talking about COVID-19. We're living in strange times. I doubt that I have to tell anybody who's watching that. The COVID-19 pandemic that began last year has resulted in over 30 million infections and 600,000 deaths in the United States. The development of vaccines has led to optimism that we may be turning a corner in our fight against the coronavirus. We're seeing the numbers fall around the country, and it's a great thing that this is happening. And of course, we all want to get back to normal, to a world where we don't have to worry quite so much about the health and safety of our family and friends. But as we look to a future out of the woods of COVID-19, we must also look to recommit to the fight against the opioid crisis that has been exacerbated by the pandemic and our response. The truth is, COVID has made the opioid crisis worse. On the one hand, research shows that people with substance use disorders are more susceptible to getting COVID and experiencing serious illness or death as a result of it. And at the same time, overdoses have also increased throughout the pandemic. Stress, anxiety, and isolation that are a real byproduct of some of our necessary responses to COVID. Those have combined with new and old barriers to treatment to create a perfect storm for the opioid crisis to get worse. Drug overdoses in the United States resulted in over 83,000 deaths in the 12 months ending in July of 2020. And you heard Tim alluding to a similar time period right before that. So this was at the very beginning. We saw that those numbers of deaths continued to increase nearly 25% compared to the 12 months before. And we've seen that trend continue since that time. Now, I always say, because I have a background in public policy and public health, and for folks in those professions, you know, we're always looking at the data. It's easy to get lost in the numbers. But I think we also have to pause here and just recognize that every one of the lives we've lost to COVID or overdose represents somebody's father or mother, somebody's son or daughter. It's people's brothers and sisters. It's all of our neighbors and friends and coworkers. Every single one of them is a newly empty seat at somebody's dinner table. And they're all missed by the people who loved them. So it's the loss, and it's also this circle of devastation around them. The deaths are tearing at the fabric of our communities. Now, the addiction crisis seemed like it was plateauing, like maybe we were turning a corner. About 2 years ago in 2018, we saw that the numbers of overdoses for the first time in over a decade actually decreased a little bit. But then even before COVID started, the trend started to worsen. And with COVID-19, things deteriorated really quickly. And the scary thing for the building trades industry is that employees in the construction field are consistently among the workers with the highest rates of heavy alcohol use and addiction issues. A lot of the data comes from the US Substance Abuse and Mental Health Services Administration. They do an annual national survey on drug use and health that, for people like me, is totally fascinating, and where we can see a lot of these trends that are happening in the country. And it shows that for heavy alcohol use, the construction industry ranks second. And for all other addiction issues that they measure, we're consistently in the top 5, coming in second, honestly, for the vast majority of them. Now, I don't have to tell you that building trades are demanding jobs, and we've already been talking about this. They're hard on the body, they're hard on the mind. And historically, workers in our industry have had a culture of toughness, just getting the job done and working through the discomfort. Workers in the building trade, as we've discussed, often don't get paid if they don't work. There are very few opportunities for paid time off. So it's easy to decide that if a medication can help you get through the workday, even if it hasn't been prescribed by a doctor, taking the pill makes sense. Managing pain is by far the top reason that Americans across the board, not just in the building trades, report misusing prescription painkillers. It's actually the reason given by over 66% of people who answer the National Survey on Drug Use and Health. And I bet, although I haven't seen the specific data, that number is probably even higher if we look only at the building trades. But taking a pill to make it through the workday too often spirals out of control, and we've unfortunately seen the results. And not only that, our workers and their families have not been immune to the stresses of the past year. Whether related to their own jobs or their spouses and other family members, the economic toll of this pandemic has fallen heavily on working families, with all the stress that brings into the fold. The fear of getting sick, and again, the possibility of missing work and missing out on pay create anxiety and burden our families. So we also have to be cognizant that not only are our workers at risk themselves, but their families can be struggling with addiction as well. Okay, so that's the bad news, but it's not all bad news, I promise. There are things we can do as an industry, and I also have to say that I love the things that Cheryl was talking about. It sounds like UA and the folks you're partnering with are just doing amazing work. One of the things I've gotten to do over the years is work with dozens of state and local communities, trade associations, and businesses to develop community-wide plans for responding to addiction. And I am a firm believer that this crisis both affects all of us and gives all of us a chance to be a part of the solution. There really is a role for everyone to play. That's why I've been so happy to be a part of RALI, because I think RALI really walks the walk and talks the talk and walks the walk on this, and recognizing that there's a role for everyone in addressing the addiction crisis and bringing together stakeholders representing a whole range of diverse perspectives, with the common understanding that we can all work towards ending the opioid crisis. So what can we do as an industry? Well, first and foremost, we have to ensure that workers have good health insurance that covers substance use disorder screening, prevention, and treatment. One of the top reasons that Americans give for not accessing addiction treatment when they know they need it is that their insurance doesn't cover it or makes it so hard to get. We also have to break down the culture of working through excessive pain. And you've heard a lot about that being one of the challenges in this industry. That can start with offering paid time off to workers who need medical treatment for acute or chronic pain, so they don't have to turn to unprescribed medications to get through the workday. And I know these aren't easy solutions. It's easy for me to rattle them off as the guy who gets to come in here and talk about these things. I know these aren't easy solutions, that there are real dollars and cents behind these issues. But I think if we really do have to invest in the health and safety of this workforce. And I think, that there's a good business case for doing that for our workers. And we can also support workers and their families by offering employee assistance programs that help navigate personal crises and behavioral health disorders like addiction and mental health problems. Now, we can do that by allowing people to come seeking help. And I think also in response to the question about drug testing, well, what happens when somebody fails a drug test? Do we just say, you're not welcome here anymore? Or do we connect them with a program that can get them back into a position to get back on the job site? Now, there's a tension in the building industry between job site safety, as we heard, on the one hand, and workers feeling they can be honest about a problem with drugs and alcohol. Obviously, we can't take the risk that employees are going to be unsafe on the job because of alcohol or drug use. The places where people are working, safety is paramount. But zero tolerance policies mean that people keep problems secret until they've gone way too far. And I'm not sure that doesn't occasionally make our job site less safe than it would be. Addiction is a progressive disease, and the sooner we intervene, the more likely we are to be able to get it under control. So we have to find ways to encourage people to seek help without worrying they'll be out of a job. And there are actually some other industries where safety is absolutely as paramount as it is in the building trades, like healthcare and air travel, that have found good ways to keep workers on the job while also ensuring accountability and safety when it comes to addiction. So I highly encourage folks to look at, there are employee assistance programs that I think are great models for physicians as well as airline pilots. And I think airline pilots is a great example of a workforce where we absolutely cannot tolerate substance use on the job and the safety concerns that creates. But they really do have a great model for how they ensure that their pilots are getting the help they need returning to the job as soon as it's safe to do so, and then held to a very high level of accountability to make sure that those problems continue to be addressed and not recur. So sometimes it can feel like COVID-19 has taken away so much of our control over our lives. Thinking about the additional crisis of drug overdoses and addiction and what we can do as individuals to keep ourselves and our loved ones safe can feel pretty overwhelming. But there are a few easy steps that we can all take to be a part of the solution. One easy thing to do is prevent medications from being used in ways that can contribute to addiction by safely using them, storing them, and disposing of them. Safe use essentially comes down to taking medications only as prescribed by a physician and making sure your doctor knows about all medications you're taking if you have multiple prescribers. Safe storage means that medications are locked away or out of reach of children, and we never share prescription medications with family or friends, even if we think it's harmless and what we're doing is helpful. And that's an understandable feeling when we have unused medications that are for example, treating pain, and we have somebody who's in pain. But it really creates a strong safety issue, and not doing that is a strong prevention method. And safe disposal means bringing unused medications to take-back days, dropping them off at disposal sites that are available in many communities, a lot of times at police stations or pharmacies, or getting a home disposal product like the disposal pouches that RALI distributes. Get it out of the house if you don't need it. It gets rid of that temptation or the possibility that someone's going to find those medications and misuse them. Another thing you can do is learn more about the risks of opioids and signs that someone in your family might be struggling with a substance use problem. A good place to start is at raliusa.org, as I said, RALIusa.org. And I highly recommend taking the virtual RALI Cares tour. And you can learn a lot of things on the website there about what to look for and how to intervene if you have concerns. Pardon me. You can also learn about the opioid overdose reversal medication naloxone and get trained to use it, especially if you know someone who may be at risk for opioid overdose. And that includes people who are taking opioids as prescribed. They can interact with other medications. We can forget about having taken a dose and accidentally take a second dose. Alcohol can interact in ways that can be harmful with opioids. So even if you know somebody who is totally adhering as best they can to an opioid prescription, it makes sense to have naloxone available. And finally, reach out to people in your family, social circle, or community who may be struggling with loneliness, isolation, or anxiety that I think we've all felt to different degrees during this tough past year plus. Because the more connected we can be, the less we're going to feel the need to rely on drugs or alcohol to cope with difficult emotions. And that is especially true for our younger workers who are still in the age group before the age of 25, where the development of a substance use disorder, there's an especially high risk when we're younger. And one of the greatest preventive factors for people is to feel connected to their community in a positive way. So make sure we're engaging young people in that way. Now, we're finally turning the corner on COVID-19. Vaccinations are ramping up, and it really feels like the possibility that life will get back to normal is getting closer and closer. My family and I are getting to go back to the pool and do all the fun things we like to do in the summer. So it's time to recommit to the fight against addiction and overdose to help build a healthier and more vibrant society for everyone. I want to thank you for letting me be a part of the conversation. I'm going to turn it back over to Tim and happy to answer any questions.
Thank you so much, Mark. And we did get one question, but I think you answered most of that in your presentation. I'm going to turn that question into an invitation. And here's what I mean. The question was, hi, Mark and all, in your opinion, what is the best way to help reach those who are struggling with opioid use? What is the best way to do outreach to reach those in the midst of addiction? we work tirelessly to figure out what's best and try lots of different avenues, but we're always looking to expand those resources. And like I said, in the latter part of your presentation, you talked about what people can do as individuals. But I think as an organization representing a group of organizations, both you, us, the building trades, and the member companies of pharma, there's much that we can do together. And maybe you can touch on a little bit about how you set up kind of RALI chapters, if that's what you do or what you do in the States, and how RALI can be a resource not only to us and the folks that participate with us, but individual members of the building and construction trades who work with us.
Yeah, absolutely. And I appreciate the question or / invitation, Tim. So in the states where we have developed official RALI chapters, we really have sort of a very open invitation to organizations in that state who want to be a part of the solution, whether they're representing law enforcement and first responders, the biopharmaceutical industry, healthcare, pharmaceutical associations representing businesses as well as professionals, building trades, as you know, and other business groups. We invite educators, and the common thread is only that everyone is interested in being a part of the solution. And because of our affiliation with pharma, we are able to bring resources in to support education, to lift up those best practices and programs that are working well in the states we're working in. And we're also able to go beyond that as a national organization and say that even in states where we don't have an official RALI chapter, we are here to support groups with our educational efforts, with training opportunities. And beyond that, we're always looking for ways to partner with organizations that are trying to do good work. So I'd also say, that the invitation is open for groups to reach out and figure out ways that we can work together. We want to do that.
Well, we've got folks on our own that work closely with us in about a dozen states. Sometimes they may overlap. We work in places where there's density, both of the industry and our union brothers and sisters. But we're also, we can also talk policy. You mentioned dollars and cents. One of the things I think that we can work on is coverage. And not only in terms of treatment of people who are ensnared in substance use disorder, but also, it's expensive and time consuming to go to PT. And sometimes the insurance companies say, why don't you take the 30-cent pill and get back on the job, rather than having us approve a regimen of physical therapy that will really do the job for you. So there's myriad things that we can work together on. I hope Cheryl and Mark and I and all of us can talk together and look for ways that we can intersect in these places where we're active. And thank you very much for your presentation.
Tim, thank you so much for having me. I'm looking forward to the conversation continuing and opportunities for us all to work together. There's a lot of work to do, so I think we all need to join forces and roll our sleeves up. And I think the building trades give us a good example of what that looks like to get it done.
That's right, on time and under budget, hopefully.
That's right.
Well, listen, this concludes our webinar on this particular subject, but it's the start, as Mark said, and as Cheryl mentioned, the start of a longer conversation. There's a lot of work to do. And we've got brothers and sisters on the job site, family members of those workers in the industry who are assailed and vexed by this deep and troublesome condition in our country. We hope that we can work on the policy frontier, but also ways to help save lives. Pharmaceutical industry, companies care about their patients, and the building trades care deeply about their members. And on that platform and that basis, I think there's much that we can do together. So stay tuned for our next briefing in our series of webinars. It's going to be on an exciting new study that PILMA has just sponsored. We got the results from an examination of about 14 different states in the country, and the amount of union construction work that the biopharmaceutical industry has invested in putting our members on the job site just a little tease of a headline, $29 billion in investment by the biopharmaceutical industry, resulting in well over $775 million in wages for union construction workers in 14 states. We're going to dive into that a little more and tell you about it. And we hope that you'll join us then. If you have any questions about this subject or the previous subjects, please don't hesitate to contact us, and we can get you hooked up with resources to help in anything that you'd like to be interested in. Thanks so much, and we hope you have a good day.